Hi everyone. It's a pleasure to participate in this presentation and discussion this afternoon. As James said, my name is Bethany Rogerson and I work with the Health Impact Project. The project is a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trusts, and our main goal and focus is to promote and support the use of HIA as a tool to ensure that decisions in non-health sectors, whether at the local, state, tribal, or federal level, are made with health in mind. We support the growth of the HIA field in the U.S. in several ways, one of which is providing funding to organizations who wish to undertake an HIA. I wanted to highlight this because we just recently announced our third round of funding earlier this month. For participants on today's call that are considering conducting a health impact assessment, I encourage you to visit our website, healthimpactproject.org, for more information on this opportunity and to sign up for our email updates. Here's a quick overview of our presentation today. I will provide a broad overview of HIAs. I'll briefly define HIA and talk about how it can add to a decision-making process. I'll talk a little bit about the field in the U.S. and how it's being used, how it can be used to connect bicycle and pedestrian safety and health, and I'll briefly end by talking about some resources to point you to if you're interested in conducting an HIA. And with that, I'm going to jump right in. More and more, we have an understanding that our health is largely determined outside of our doctor's offices. Research shows that the key factors which drive our health are where we live, work, and play. This diagram provides examples of the social, political, and environmental factors that relate to health. And these include factors such as transportation, education, diet, and exercise. However, many decisions are made that influence where we live, work, and play without consideration of the impact to health. Consider some of the decisions that have contributed to the childhood obesity epidemic. Urban planning and transportation decisions inadvertently engineered physical activity out of everyday life. Transportation and urban planning decisions, for example, influence sprawl and can drive patterns of traffic injury, asthma in children, and levels of physical activity, key factors in the emerging epidemics of obesity and type 2 diabetes. The problem is that many of these decisions are made in sectors far outside the traditional scope of public health. And because health isn't their primary mission, they are often missed opportunities to improve health or unintended negative consequences. That's where HIA comes in. Health impact assessments are a way to evaluate the potential and often overlooked health effects of a proposed policy, project, or program. Here is how the National Research Council most recently defined HIA in their report released last fall. I won't read it in full, but would like to emphasize several points. First, health impact assessment is a process, not just a study or evaluation. It uses multiple methods, qualitative and quantitative, and brings the best available evidence to make predictions. HIA translates public health data into practical recommendations that decision makers can use to ensure that their policies contribute to healthy communities. HIAs also recognize trade-offs and look at the potential costs and benefits of various choices and outline opportunities to maximize health gains, minimize adverse effects, and improve health. Additionally, HIAs view health from a broad perspective. They look systematically across the entire spectrum of factors that drive community health and take into account a wide range of environmental factors such as housing, roadway safety, employment, environmental conditions, and social factors that lead to health outcomes. As we discuss what HIA is, you may hear some of these activities or steps of HIA sound familiar to the work that you're already doing. I often think of HIA as packaging some of those activities into a process to look at health impacts of a proposed project or plan. And because it may sound familiar, I think it's also helpful to think about what HIA is not. It's not a way to say, yes, this project should move forward, or no, this project shouldn't. As I mentioned on the last slide, HIAs focus on highlighting the benefits as well as the risks, and provide practical recommendations for maximizing benefits and minimizing negative consequences. HIAs are sometimes confused with other types of health assessments that are generally narrower in scope and are not designed to inform an active decision-making process. You may use tools like a community health assessment, for example. And while HIA is different, you may use some of these tools during the assessment phase. Lastly, I also wanted to note that HIA is one tool, but HIA is not the answer to every health problem or the best approach for every decision-making process. And I'll talk more in a second about screening where you can decide where your HIA will add value so that you're not duplicating efforts. So what is the HIA process more specifically? HIA typically involves a 6-step process, beginning with screening projects and deciding whether an HIA will add value. This is a key step to determine how the HIA will contribute to the decision-making process. This might involve consideration of other related activities on the proposed project or examination of available resources, as well as consideration of whether health is already at the table. The second step of HIA is scoping, which determines the important health effects. This is where you create objectives for the HIA and outline the steps of the assessment by also asking who will be affected by the policy or project and how. Assessment involves 2 steps. First, describing the baseline health of people and groups affected by the decision, and then predicting the potential health effects. An HIA then involves developing clear and practical recommendations based on these findings and reporting or disseminating the findings of the HIA. The last steps are monitoring and evaluating the process, impact, and outcome of the HIA. I also just want to briefly mention some key underlying values of HIA. We see HIA as a flexible approach that can be tailored based on the project objectives, resources, and other factors. And practitioners conduct HIA differently, but aim to accomplish several key values, including democracy, equity. HIA assesses the distribution of impacts from a proposal on the whole population with a particular reference to how the proposal will affect vulnerable people. Other values include sustainable development, ethical use of evidence, as I mentioned, bringing together the best available resources, both quantitative and qualitative, as well as a broad definition of health. There are many benefits to HIA, and I'd like to highlight 2. First, it involves a broad range of impacted people, including community, business leaders, and decision makers, to name a few. And it really is a meaningful tool for operationalizing collaboration across sectors, such as transportation and health. It can be a forum to create a common language, find shared data sources or indicators, and build relationships. These partnerships and the trust that is built among partners through the process increases the likelihood of routine consideration of health in the future. Stakeholder engagement is a critical component of HIA that should be part of every step in the process. Community's input on an HIA scope, finding, and recommendations can ensure that the analysis is accurate within the local context. And I think this can be a particular value add for bicycle and pedestrian safety and health HIAs. In response to a proposal for an urban greenway with walking and bike trails in the East Bay along the Bay Area Light Rail Corridor, for example, many community members suggested that they would be unlikely to use it because of concerns about criminal activity. And the HIA recommendations and that knowledge from the local context led to recommendations for design that discourages crime and better policing along sections of the greenway. Also, when we talk with people who have completed an HIA about what they feel is the main impact of their work, they often point to the collaborations built through the HIA process and the ability of HIA to shift the dialogue or bring health into the conversation where it might not otherwise have been. I'd like to transition from the definition of HIA and say a bit about the field in the U.S. to give you a sense of where HIA has been done and what issues they've addressed. The field has really grown exponentially in the last several years. In 2008, there were only 27 completed HIAs in the U.S. This is a recent map of all of the HIAs that have been completed or in progress to date, and now there are over 200 completed or in progress HIAs across 25 states. Regionally, as you might be able to see, the West Coast has been the most active in HIA, with California and Oregon having completed or working on close to 100 HIAs. But other states and regions around the country are certainly becoming hubs of HIA activity, and there are a lot of states that are just getting started. We're always eager to learn of new HIAs, and you can visit our interactive map on our website to see HIA reports. Our map is where we track activity across the country, and if you know of an HIA that is not currently on the map, we strongly encourage you to submit a short form on our website to add any new HIAs that aren't represented. In addition to where they're being done, I want to say just a bit about what topics they address. HIA HIAs cover a range of topics, including agriculture and food, labor and employment, housing, education, and gambling, among others. But the most common decision areas where HIAs have been conducted pertain to the built environment, transportation, natural resources, and energy. There are certainly many other topics to which HIAs can be applied beyond the categories listed here, an opportunity for the field to continue to grow. As I've mentioned, HIAs aim to address the root causes of health outcomes by asking the question, how might this particular decision affect the many social determinants of health, such as the ones listed here in the middle of the slide? During today's webinar, we'll focus on transportation and bicycling and pedestrian modes of transportation in particular. And as you can see, transportation is among the social and environmental factors that influence our health and well-being, and has therefore been a factor considered in many HIAs. This slide shows some of the ways that bicycle and pedestrian transport connect to health. They relate to several other factors that directly or indirectly influence health and well-being. For example, the characteristics and qualities in the built or natural environment, such as roadways or air quality, have implications for bicycle and pedestrian transportation. And HIAs can connect these to health by looking how changes might affect physical activity, as well as implications for safety, access to goods and services, including something like fresh foods. There have been a number of HIAs focusing on decisions and issues with implications for pedestrian and bicycle safety, and we'll hear two specific examples in just a few minutes. There have been HIAs of land use, transportation, and comprehensive plans, such as those listed here, all that consider pedestrian and bicycle environment. Every decision is different, but recommendations that have emerged from these assessments often emphasize things like the importance of traffic calming measures, complete street design, and crosswalks and sidewalks. I'd like to wrap up my presentation by providing an abbreviated list of resources, and I should stress abbreviated because these websites listed at the top can refer you to many more resources as well. These can point you to HIA guidelines, toolkits, worksheets, practice standards, training materials, literature, and many examples of HIAs, and including their HIA reports. There are also a few specific tools, including those developed by Active Living Research, relevant for measuring the pedestrian and bicycle environment. And some of these are listed here. The Spaces instrument measures the physical environmental factors that influences walking and cycling in local neighborhoods. News assesses the community perception of neighborhood design features related to physical activity, street connectivity, and infrastructure for walking and cycling. The San Francisco Department of Public Health also created the Healthy Development Measurement Tool, which contains indicators relevant for pedestrian and bicycle transport. And lastly, the Pedestrian Environmental Quality Index is another tool that was developed to assess the quality of the physical pedestrian environment and inform pedestrian planning needs. And again, these are tools that you might use in your assessment step of your health impact assessment. This is certainly not a complete list, and I welcome your questions and would be happy to direct you to more resources should you move forward with conducting an HIA. And with that, I'll close. It's been a pleasure to present today, and I welcome any questions you have about HIA or our work at the Health Impact Project following the other presentations.
Thank you, Bethany. We will now hear from Jim Skoog and Ellen Pillsbury.
James, I've lost our screen.
Hey, Jim, all you got to do is pull up your PowerPoint presentation on your screen.
I have lost it. I don't know where it is, James.
Okay, I'm pulling it up on my screen so we can look at it there. Just tell me when to click through.
Okay. Okay, go ahead, click. I'm sorry about that, folks. Just to let you know that our HIA on the Duluth Hillside Neighborhood is available on the Health Impact Project's website. Okay. Go ahead. So, as you can see from Bethany's presentation, 13 HIAs have been done in Minnesota. And most of them were on comprehensive plans or land use plans. They were the most common, although ours, of course, was on a transportation plan, basically. Duluth HIA is one of two that were done outside the Twin City metro area. The other one was of a comprehensive plan in central Minnesota near Alexandria. Okay. Our Hillside HIA had three focuses. One was the schematic redesign of 6th Avenue East. Also, we wanted to look at Duluth's complete streets resolution and general mobility in the Hillside neighborhoods. That's East Hillside and Central Hillside. I should point out that this HIA was done by a three-person team. Ellen and I were two of the members, and Kimberly Sanis, who is the principal engineer for Public Solutions Incorporated, was the third member of our team. Okay. And so this is 6th Avenue East. It extends from 2nd Street, which is the tall building in the background, is on the lower side of 2nd Street. We are taking this picture from just below 5th. The worst, one of the 2 or 3 worst intersections in Duluth is the one that you're looking at by that Super America gas station sign. It's 6th Avenue East and 4th Street. Go ahead. So this is, that gas station is just to your right. This is the same intersection, but it is looking uphill, away from Lake Superior. Okay. So the background on 6th Avenue East, it used to be a Minnesota trunk highway, 194. And when the interstate came through downtown Duluth, the Minnesota Department of Transportation decertified it as a Minnesota highway, fixed it up, and gave it back to the city. That happened in the late 80s or early 90s. It's a main arterial. It is straight from 9th Street down to 2nd. It's 4-lane, and typically, you know, it's in the city. It's a 30-mile-an-hour speed limit, but speeds under 30 are not very common. Typically, you're at 35 or maybe even 40 or maybe even more. It's a barrier for all types of non-motorized transportation. There are many crashes, and it's beginning to fail motorized vehicles to some degree also, and is an ongoing neighborhood concern in the Hillside neighborhood. Okay. So this is the dark gray is a map of the Central and East Hillside neighborhoods, and the dotted red line down the center is 6th Avenue East. Typically, there is a lot of rental housing, and the rental tends to focus on the closer to Lake Superior, on the lower elevations, and on the west or in the central hillside of the map that you see. The farther you go uphill and the farther you go east, more single-family homes are owned. Okay. The 6th Avenue East schematic redesign study was completed in late in the year 2010. And it was a surface redesign only. They didn't do any of the buried infrastructure. It was a process where they took a lot of public input. They'd go to fairs or other meetings and get input from the general public. And then they took that input to a technical advisor group and bounced it off them for a reality check. And then they went back to the public with the best ideas, and then back to the technical advisor group, and then wrote the report. This report was limited to those 7 blocks of 6th Avenue East, and they had to stay within the right-of-way. The health impact assessment that we did, of course, didn't have to do that, but they did. Okay. So our initial team assessment was that residents avoided crossing 6th Avenue East. We have a Whole Foods co-op that's just the second business in from that intersection, 6th Avenue East and 4th Street. And the manager was out for her daily walk and ran across a person on the other side of 6th Avenue East from where her work is. Asked that person, you know, if she ever shopped at the co-op. And her answer was, oh no, I never go there. Well, why not? Well, I won't cross 6th Avenue East, it's too dangerous. So that attitude is fairly pervasive, at least with parents who have young children and older folks. They just don't want to go across. There are too few bus stops. Actually, there's probably plenty right now, just maybe in the right amount, but the schematic redesign recommended fewer bus stops, and our HIA took a look at that. Also, we took a look at emergency access to hospitals. That became a concern. We have 2 hospitals in the Hillside neighborhood, and actually we have 2 hospitals in Duluth. They're both in that neighborhood. And that the residents, they wanted a vibrant, green-friendly corridor. And 6th Avenue East has got very little of that. And then the last thing is that we wanted fidelity to the Complete Streets resolution that passed in March of 2010. So Ellen is going to take it from here.
Thank you, Jim. With our assessment of the corridor and review with the public and just walking the corridor, we identified 3 main health categories that we were going to report on in our HIA. And we chose these categories mainly because of the kind of our time constraints, and then just to make sure that we were able to, to fully look at these 3 areas. So let's see. Next, our first health category was accessibility and safety. And under accessibility and safety, we identified a few health indicators, and I was going to share 2 of them with you now. The first one being, we looked at the bus accessibility, bus stop accessibility, and as Jim mentioned before, within the report, the schematic redesign study mentioned removing some bus stops. We suggested as a recommendation to add stops and even install some shelters to make transit more accessible to residents, especially since 6th Avenue East is on a hill, and having to walk more than a half a block to a bus stop would be a barrier. The second major health indicator were the number of crashes on 6th Avenue. If you could advance to the next slide. we discovered that, and this is hard information for us to get, we discovered that at the intersection of 6th Avenue East and 4th Street, there had been 139 crashes, which involved, in 5 years, which involved bicycle pedestrians. This information was hard to come by, but once we were able to collect it, we found out that it was one of the highest crash areas in our city, and recommended that this be more closely monitored and a better system of reporting maybe put in place so this data could be utilized better by city staff to apply some mitigation safety measures because of the number of people that cross that street and just the high rate of crashes we've seen in the past. So next slide. Moving on to the physical activity category, the two key indicators we looked at were first the City of Duluth fairly new comprehensive plan, and then also newly created Unified Development Code language. And we saw within the UDC guidelines that there was support appropriate to make some changes along 6th Avenue East when there was a redevelopment along the roadway. And the UDC was pretty focused on making pedestrian and bicycle-friendly at least site design. We also, at this time, there was also a neighborhood plan planning process being done almost simultaneous with our HIA, and so as part of our HIA, we did review the older neighborhood plans, and we saw that they were looking like they were leading towards doing one complete neighborhood plan instead of a hillside and a east hillside. East hillside plans. So just the combining of those neighborhood plans are a good indication that physical activity will be addressed in the neighborhood plans along with the comp plan and then the UDC. And so we recommended that they monitor the implementation of these plans, for healthy environment development. A program that we looked at, which is, we can't really read it here, but we looked at, because this is a snowy place, a new program came into place while we were working on this project too, where we looked at how our sidewalks get cleared with snow. And as part of our HIA, we wanted to support that program and hope that in the future we can have a more sustained effort to clear the snow and ice from our sidewalks. The program that's underway was a kind of volunteer-only program. Moving into our last category that we looked at was the livability category, and the main health indicator, top health indicator here was the amount of just unattractive parking lots around our medical district. You can kind of see in this picture, there's this gray island in basically the middle of the slide, or the middle of the photo. And right around, neighboring all the gray islands, which are, medical buildings and also surface parking lots, are neighborhood housing. So it came up in many public meetings, and just the need to make these unattractive parking lots, better neighbors for the residents. And we saw that we recommended that within the UDC that there were parking standards that focused on green improvements. And so, hopeful as a recommendation that in the future, as these parking lots get reconstructed, that they are focused on the pedestrian and bicycle interaction with them. So moving on to how are we working on reporting the final study we've done. So far, you can go to the next slide. So far, the report is complete. We've distributed it to the city and a number of stakeholders. We've done a press release and we've met with the city staff. The one area that we weren't able to accomplish was we didn't have a kind of a media event, but hopefully we just ran out of time. And then towards the end of the year last year, we presented our HIA report to the city council, and it went well, except for we should have probably waited a month or two because the new councilors hadn't been seated yet, so we had to kind of go back and follow up with the city councilors. So the city staff, elected officials have all been received presentations on this report, and it is now an addendum to the 6th Avenue East Schematic Redesign study. Moving on to the monitoring phase, now that this report is done. Right now, the physical surface of the avenue is not really in bad shape, so it makes reconstruction a few years off, or several years off actually. And this actually might be a good thing because the city is still learning how to best implement road projects under its new Complete Streets resolution, which was passed in March of 2010. And so we hope that when this project finally is ready for reconstruction, they've had a number of practice projects to complete streets, so this one will go very successfully. And then our HIA report is being the recommendations are kind of being monitored by public health and then by a number of neighborhood groups that participated in putting the report together. So it should be a good guidance document for all of us. And then in conclusion, HIA, we paired this HIA with the redesign study, and now because of the study and the HIA, there'll be an upcoming traffic study of the avenue done by our MPO, and the HIA recommendations positively affect the health categories that we looked at, and we see that the city's comp plan does support many of our recommendations. We do see it in the neighborhood plan. So if implemented, it will improve the health of our residents, especially in that neighborhood. Also, next slide. The roadway redesign is feasible. Especially some of the out of the right-of-way changes are feasible. And with having a number of years to do the planning for the redesign construction work, there's a really good opportunity here for a really good design to be put in place. And being able to think outside the right-of-way will allow for more livability concerns to be addressed, which will truly unify these two neighborhoods. And so I stay tuned. This HIA should be a good foundation for a new 6th Avenue East that's more livable in the years to come. So with that, I thank you.
Thank you, Jim and Ellen. I will now pass the screen over to Brendan.
Great, thank you. All right, thanks so much. My name is Brendan Haggerty. I work for Clark County Public Health in Vancouver, Washington. And today I'm going to tell you about an HIA we conducted on the county's bicycle and pedestrian master plan, which was adopted in 2010. I'll start by just telling you a little bit about what's in the plan, the one that we evaluated, the subject of our HIA. Then talk about the approach we took to health impact assessment, which was a little bit unusual. I'll get into some of the recommendations we made, And then I'll try to leave lots of time to talk about the evaluation we did of the HIA and the lessons we learned from that. What you see on your screen on the right is a map of Clark County. Along the south of the county is the Columbia River, the border between Washington State and Oregon. So we're just across the river from Portland, Oregon, and it's a largely suburban county. The largest city is Vancouver, which is about 170,000 residents. The county as a whole is 430,000 people. So it gives you a sense of where we're working. So like most bicycle and pedestrian plans, we had three main kinds of proposals that appeared in our bicycle and pedestrian master plan of 2010. We had programs, which are largely education and encouragement efforts like safe routes to school or promoting scenic bikeways. Projects, which are things you have to build, like bikeways or sidewalks. That's the infrastructure. And policies, which direct when, where, and how much of each program and policy we are going to engage in and implement. And oftentimes when I explain about this HIA, people say, well, you're doing an HIA on a bike and ped plan, and biking and walking is good for health. So what all do you have to assess? It's kind of a no-brainer, right? But we really tried to focus on how we could maximize the health benefits of biking and walking through active transportation, and especially how we could address disparities in health outcomes and in health determinants that we observe in our county. So to talk a little bit about our approach to HIA, what was unusual about it is that we did both a rapid HIA and a comprehensive HIA. And the reason we did that was to have early input into the planning process. The rapid HIA allowed us to do that and to introduce some of the key ideas early on in the process before much of the plan had been finalized. The comprehensive HIA came further down the road, and that enabled us to provide really high-quality data to our decision makers. In each case, we did an extensive baseline assessment where we looked at conditions currently existing on the ground. We looked at the proposals and estimated impacts from those proposals, and then we made recommendations. We shared those recommendations with the key decision makers for the bicycle and pedestrian plan. And in this case, there were two groups of decision makers. One was the planning committee, which was made up of stakeholders and citizens, and another one was the Board of County Commissioners, which is 3 elected officials. And I'll get back to that when we come to our evaluation. For the baseline assessment, we compiled lots and lots of different kinds of data having to do with demographics. We looked for health outcome data, which was much more hard to come by, but we looked for overweight and obesity at the most specific geography as we could get it. We looked at crashes, access to resources such as parks, trails, healthy food, and other health-promoting resources. And then we looked at a lot of measures of the built environment that contribute to walkability and bikeability. And actually, I'll go back to that previous slide and just explain. The map that you see here on the left is a map of walkability by census block group. And that's based on a walkability index that was developed by researchers associated with active living research. So this index is important because it is associated with physical activity in the research literature. So that helped us bridge what we knew about what's on the ground and what we could expect in the future. The walkability index is a measure. It's a combination of many built environment measures such as density, floor area ratio, street network connectivity, and land use mix. Back to the baseline assessment, this is an example on this map of some of the demographic information that we collected. And so this shows median income by block group. Our approach in the rapid HIA was to find where conditions overlap to either create a high potential for physical activity or a high need for physical activity. So we looked for areas where health outcomes were poor, where socioeconomic status indicated a great need, and where the built environment variables either demonstrated a high potential or a great need for investment in bicycle and pedestrian infrastructure. We then took the proposals in the plan and established a service area for each of them, and that's what's shown in this map. So there's a buffer around each facility, and we looked at the population within that buffer, assuming that was the service population for each facility. And we compared those populations by neighborhood and by school attendance area, mostly looking at differences by socioeconomic status. But we were really looking for impacts on disadvantaged populations. And those included racial and ethnic minorities, low income or low socioeconomic status populations, the very young, and the very old. Our findings showed that we estimated about 95,000 residents would be served within a half-mile of their home by one of the new facilities if they were all built out. And if they were all built out, about half of the proposed sidewalk miles and 45% of the proposed new bikeway miles were in low-income neighborhoods. And that's important because of some of the recommendations that I'm going to get into next, which came early enough in the process to help us influence that breakdown. The recommendations from the Rapid HIA are on the screen in front of you. Among them were low-speed designs in a variety of facility types, not just sort of the bike lane on the arterial. Some of them were really aimed at connecting land use to transportation in a closer connection. So we had a lot of land use policies, parking programs, and then the one that I want to highlight mostly is the one at the bottom, include health and equity criteria. And if you'll recall in the last slide, I showed that about half of all the new facilities were in low-income areas. And one of the reasons for that is because when the planning committee went to create prioritization criteria for this big, long list of potential projects, they looked at this recommendation and said, okay, we're going to weight health and equity at 20% in our overall weighting. So out of a 100-point scoring system for each project, they weighted 20 points were allocated to health and equity. And we further broke that down based on socioeconomic status, the walkability potential, and the types of facilities and their potential to generate physical activity. Now I want to talk about evaluation that we did. Health impact assessment is, as a field, is still kind of lacking in a lot of evaluation. So I like to promote this among those who are interested in health impact assessment and who have conducted them or are considering it. This is a really important piece. There are three kinds of evaluation that are typically discussed: process evaluation, impact evaluation, and outcome evaluation. We focused our evaluation on impacts, where we were looking really at how the HIA affected decision-making related to the bicycle and pedestrian master plan. We did that in two ways. One of them was simply a qualitative comparison, where we compared our recommendation to the adopted plan and then made a determination as to whether that recommendation was adopted, not adopted, or even partially adopted. And so in this example, the recommendation I was just talking about, include health and equity as project prioritization criteria, we found that it was fully adopted and that the planning committee allocated 20% 50% of the decision-making weight to health and equity. The other way that we evaluated the impact of the HIA was through key informant interviews with decision makers. We interviewed several of the planning committee members, we interviewed planners, and we interviewed our elected officials. And then in analyzing those responses, we extracted a few key themes, and examples of those are on the screen. We knew that from the responses, we knew that people recalled having been exposed or having heard about the HIA. We knew that they used it. And many of our respondents said that the HIA broadened their perspective and increased the understanding of the consequences of their decisions. And importantly, the respondents said that the HIA exposed equity issues that were not brought up elsewhere. We had one respondent say, without this, that wouldn't even been on our radar. And that really helped us know the impact of the HIA and whether or not we were meeting some of the goals that we set for ourselves. So we'll close up with some lessons learned. One of the strengths of this HIA was the early involvement that was afforded by the dual approach of doing a rapid HIA and a comprehensive HIA. Being involved early and sitting in on the planning committee meetings all the way through, being there as a resource and a reference, really gave us a lot of credibility and also helped us shape the plan early on rather than having to revise it down the road. The extensive baseline assessment helped us also gain credibility and really filled out a lot of the gaps that were in the baseline assessment that was conducted just as a normal part of the plan. And then I'd say the final strength of this effort was the collaborative relationships that we built with planners, with public works officials, with consultants, and with citizens. And that has led to subsequent HIA efforts and recently an effort to add a health element to our comprehensive plan for the county. So that was a real takeaway for us. Some of the challenges that I want to point out are the data needs. As I mentioned, getting health outcome data at a fine geographic scale is really difficult, and that often results in us not being able to answer the questions that were asked by some of our stakeholders. I have state of the science on here because I just want to point out that sometimes we're asked to estimate the number of calories that people will burn while they're riding on the new bike lanes that we're putting in for 3 blocks or something like that. And while the art and science of travel demand modeling for bicycles and pedestrians is rapidly advancing, I don't think it's quite to the level that the level of being able to do that. And that's closely related to what we're asked by our decision makers. And they're asking both for a high level of quantification and to put that in economic terms. So not only how many more additional bicycle trips are we going to get out of this bike lane, but how much money will we save from reduced trips to the ER, for example. And that just wasn't a level that we were able to reach. In other challenges, communicating the data, oftentimes, data people, and especially epidemiologists, like to emphasize the caveats to everything, and that's really important, but it doesn't always communicate well working on a really diverse stakeholder committee. The timing is a consistent problem in HIAs, and it was a problem for us that we really didn't get final proposed projects until very late in the process. They only finalized the plan about a month before the final hearing, which left us scrambling to do as much impact assessment as we possibly could in that short amount of time, and then disseminate it. So those were some of the challenges, and I would encourage you to check out the documents at the website on the slide here. And I will now pass it back to James, and we can do some questions.
Great, thank you, Brendan. And now we will go through some of your questions. The first one, I'll just start with this one. If you haven't asked your question yet, go ahead and type it into the question box. I've already gotten some, so I will start with those. Bethany, is there anything in the new transportation bill that supports or requires HIAs?
That's a great question, and I unfortunately don't feel like I can give a full or accurate answer, but I'm happy to either defer to one of the other presenters, or I'd be happy to follow up, but not to my knowledge at this time.
What does an HIA cost?
The cost of HIAs can really vary. I think it's important to emphasize that HIAs are a flexible approach that can be scaled to achieve different objectives, as well as different timelines or scopes of the project. And the second part of HIA scoping is really where you can look at the universe of health issues you might want to look at, and then determine which are the most important ones to look at in the time and given your capacity and expertise and resources. We found that HIAs can be done in a matter of weeks, something like a rapid HIA that might take the form of a comment letter or some other shorter report, and that might cost some limited staff time or a couple of thousands of dollars, for example. Up to a more comprehensive HIA that might involve more complicated or expensive modeling, for example. Our grants have ranged from $25,000 to $75,000 in this next call for proposals. And in the past, we have funded HIAs up to $150,000. But that is more towards the comprehensive HIA, and then again, I think it can vary.
Okay. My next question is for Jim or Ellen. I got a couple questions submitted about the bus stops. And one perspective was that additional bus stops might reduce or increase travel times, and would that discourage bus riders? And also, would increasing the number of bus stops shorten the amount of time people walk, which would affect obesity? Were those issues at all that you guys considered?
Yeah, this is Jim. We did consider that, and the input from the residents were that there were several folks who if they had to go up or downhill to catch the bus because of the fewer bus stops recommended in the schematic redesign study, that they would not be able to manage that even in the summertime, that they could walk parallel to or at right angles to the hillside, so they weren't going up or downhill. But if they had to go up or down, that would eliminate busing for them. And this is a residential area that has a high degree of poverty, and many of those folks just busing or a taxi or bumming a ride is how they get around. And so we felt that encouraging more people to take the mass transit, take the bus, was an important thing to do.
Okay. Brendan, I've gotten this question from several people. Where did you get your obesity or overweight data?
That's a good question, and so we relied on the Behavioral Risk Factor Surveillance System for that, and that's a national survey that's designed to compare states and counties, It's not necessarily designed to compare smaller geographies. Some jurisdictions purchase additional responses or additional questions that allow them to do a better job of comparing at a small geographic scale. But examining differences in obesity and overweight spatially is something that we've really struggled to do very well. What that is, it's really common for that sort of problem to be an issue. So measuring a health outcome is pretty difficult, but what we know from the literature is that there are pretty clear determinants that we can measure a lot easier. So mostly we focused on measuring determinants rather than outcomes.
Okay. I also want to follow up with you, Brendan. Is there any standard set of metrics to make biped studies comparable?
I'm not sure I understand the question. Does that mean HIA specifically or bike and ped studies generally?
I think it means HIA specifically.
So there have been very, very few HIAs that have, well, I should say, there's a rapidly expanding number of HIAs focused on bicycle and pedestrian issues. But HIA as a field is pretty new and is also remarkably flexible. So there's not, to my knowledge, an established set of bicycle and pedestrian indicators. But I think a lot of the work that has come from researchers like Jim Salas and Larry Frank have really set some good examples of indicators that you can use. That walkability index is a helpful one, and the same thing is happening with bicycle research as well. So I would encourage anyone looking for sort of typical or standard indicators to consult some of the research and find what they've defaulted to or have eventually honed in on.
Here's another question I just got. What can we do to make sure that transportation planners or engineers start to include health outcomes beyond just safety as a core part of their job description?
James, this is Bethany. Was that a question for me? I'm sorry, I had trouble.
For whomever wants to take it.
Well,
yes.
I might just, oh, go ahead.
Okay, this is Brendan, and I would say in our experiences here, having that group at the table every step along the way really helped increase understanding, not only of sort of the relationship between transportation infrastructure, land use, and health, but also of the disparities that are experienced by certain populations. And so just involving them was a big step forward. Looking ahead, if there's a way to include sort of a health review or a health checklist along the lines of the Healthy Development Measurement tool that was developed in San Francisco, that's a good way to sort of institutionalize that relationship. Do you have anything to add, Bethany?
I completely agree. I would add that HIA can really be the starting place for that conversation, and to have that place to find the common language and perhaps compare different data sources and see where there might be differences and overlaps. And also to say that in some cases, that relationship may already be more established, and you may be in a position or further along the way of connecting transportation and health. But I think HIA can be one tool to start that conversation where those relationships may not exist.
Okay, this question is for Bethany. Have any HIAs been done on policies that are being reviewed or possibly edited? The examples presented today were more on a plan for the built environment, I'm specifically talking about a school district that is considering revision of a policy that prohibits students from biking to school.
That's an interesting topic. I don't know of an HIA on that particular policy, but certainly HIAs can be conducted both on projects and programs as well as policies. And I think the key thing is to look for a policy that's under active consideration and a policy that you're able to insert the HIA to influence that discussion. We've seen HIAs on policy topics outside of built environment, such as education, and sometimes those things overlap, or housing, for example. But certainly, the short answer is yes, HIAs can address policies.
How are the health impacts determined for children and the frail or elderly, neither of whom can speak for themselves? These two groups are really held almost captive by caregivers due to fears of traffic and other threats.
This is Bethany. I would say that I think, as I think both Brendan and Jim talked about, HIA can address community concerns and provide that local context, and provide a way to address those concerns. I think that HIAs also, while looking at the complete affected population by the proposed changes, do also focus on vulnerable populations such as the elderly or children, to address how impacts might be distributed differently among different groups.
Okay. Brendan, did you find that the concept of health equity was regularly understood in your multi-stakeholder group, or was that something you had to bring people up to speed on?
Well, it was not a uniform group of people, so some of them got it right away, and some of them took a little bit longer, and some of them never got it. So, regardless, it was really helpful to discuss that topic in depth and to return to it multiple times, because it raised the importance of that issue and helped us focus on it in the way we made our decisions.
Okay, thank you. Have any of these projects looked at impacts on specific diagnoses beyond obesity, such as COPD, diabetes, or hypertension?
This is Bethany. I would say that HIAs look at a range of health issues. Certainly obesity and diabetes are some of the top health concerns in our country, and so HIAs often touch on those issues and address them, but HIAs can look at the whole spectrum of health issues. Injury and safety was a topic of our conversation today, and that's certainly part of an HIA, as well as other things like asthma and some of the health outcomes that were mentioned there. I would also say that HIAs also look at things like stress and mental health issues as well.
Thank you. Have any of you experienced where some of the stakeholders disagree with part of the HIA findings? And if so, how did you handle that situation?
This is Brendan. I would say that some of our findings were met with skepticism, not necessarily outright disagreement or confrontation, but I think we were fortunate that many of the planning committee members had really tuned in to the discussion over many months and were really up to speed and had educated themselves quite a bit on some of these. And so we were fortunate that, or I should say I was fortunate, that really other committee members responded to that and said, no, this is really important, and all this data that we've seen point us in this direction.
And this is Jim. When we presented to the City Council, they had questions, but they didn't really engage us in discussion about various facets. But when we presented to the city staff prior to going to the City Council, there were some challenges. And the one that I remember the most was both the schematic redesign and our HIA recommended a bike lane going uphill and a shared lane going downhill. And the mayor and at least one other staff person weren't convinced that that was a good recommendation. And so, you know, this whole HIA is up for discussion. And, you know, we presented why we thought it was a good idea and necessary and how we came to the conclusion. But in the end, somebody else, probably not us, is going to redesign that roadway, and they're going to make decisions. And maybe they'll take the mayor's viewpoint, and maybe they'll take the HIA's viewpoint.
Okay. Who usually conducts the HIA? Is it done by a health department staff, or do you have to hire an outside consultant?
Well, we did all of that. I work for public health, and Ellen was contracted to our statewide health improvement program in Northeast Minnesota to work on active transportation and safe routes to school and any transportation projects we would work on. And then we thought we needed to bring in the person that wrote and facilitated the schematic redesign study to actually participate in this team process of doing the HIA, partially on her study, and then these other two factors: the complete streets resolution and the livability or mobility in the Hillside neighborhood.
This is Brennan.
This is Stephanie. I would add that HIAs can be conducted and led by a variety of groups, nonprofit organizations, as well as universities, local and state health departments, or non-health agencies as well. And I think the key is bringing together a group of people with varied expertise, community engagement, as well as the specific assessment tools. And that may be housed at different locations. And so it's that stakeholder engagement that brings together all of those different partners, but it can be led by different organizations as well.
Have any of you received any sort of economic impact concerns regarding the proposed changes discussed in the HIA, and what have you done to respond to those economic concerns?
So this is Brendan. I'd say the chief concern of our elected officials regarding the bicycle and pedestrian master plan was the cost of infrastructure. That didn't relate directly to the health impacts, and so we partnered with some of the other stakeholders and did some research kind of statewide on what approaches other jurisdictions take. So we essentially deflected those.
Okay. I'm scanning through questions here real quick. Can HIAs be used to address occupational health issues such as workplace bullying and stress? And if so, is there a way to find out more about work-related HIAs?
For HIAs, I would refer you to our interactive map where you can sort HIAs by topic. And there may be some in there that address that. I don't know of one that specifically addresses and focuses on occupational health, but certainly those issues of workplace safety or stress are often issues addressed in HIA.
Has anyone done any research on the cost savings from the HIA process, as in making people healthy and driving down hospitalization costs? Has there been any correlation?
I have one example that comes to mind, although I'm sure that there are others. I think providing that economic narrative can be important, but is a new part of HIA that I think is being done more, but is still new. But one example, and I may not get the numbers exactly right here, but I recall that the paid sick days HIA done in California looked at cost savings from reducing incidences of childhood hospitalizations due to asthma, and we're able to put a dollar figure on that and connect that to if paid sick days were available to workers, how that could reduce those hospitalizations and therefore save X number of dollars. So that's just one example. It's a great question.
How long does it take to conduct a typical HIA?
Like I said, HIAs can be conducted in a more rapid format, perhaps in a matter of weeks, but may take longer. The HIAs that we've funded have ranged from about 6 months up to about 2 years. And again, that can change depending on the timeline of the decision-making and nature of the decision-making process that your HIA seeks to influence.
Okay. Unfortunately, that's all the time we have for discussion today. I want to thank our presenters again, Bethany Rogerson, Jim Skoog, Ellen Pillsbury, and Brendan Haggerty. I appreciate their time today. If we did not get to your question, I apologize. Once again, a recording and transcript of today's program, as well as a PDF copy of all slide presentations, will be available on our website, www.walkinginfo.org/webinars. It should be up within a couple of days, a week at the latest. And I want to remind you that we will have 2 more webinars coming up with the American Public Health Association in September and November, so please keep your eye out for those. And finally, I want to remind you that there will be a very brief survey at the end of the webinar, and we appreciate you taking a moment to comment on it. Thank you very much, and I hope everyone has a nice afternoon.